Hello everyone, it's Dr. Nick Taylor again. Welcome back to TiCME.com.au. I'm going to talk to you today about a topic that a lot of people in emergency departments have a little bit of trouble with, and that's chronic pain. Now, before you switch off, I just want to let you know I'm going to give you some practical advice. This is going to be a brief talk, so why don't you keep listening? So I often get involved in patients with chronic pain as the second doctor. One of my juniors have seen them, they're having trouble discharging the patient, they've worked them up medically and haven't found anything significant, and they've asked me to come and speak to the patient. Look, chronic pain's difficult in this regard, and I think a lot of us would understand that a lot of our patients maybe don't have significant underlying pathology. They've had an exhaustive workup that hasn't found anything. But the pain the patients experience is real. And for a lot of people, it's very difficult to disentangle the amount of pain they've got from the nociception or the pathology that's causing it and the amount of stress in their lives. So I get to know my patients a little bit first. I sit down and talk about something other than their illness. I try and de-emphasise the tests. And then I have a conversation with my patients about their pain, and this is how I do it. I ask them whether they've ever been overseas. I tell them that they're planning a trip overseas to a tropical country. It might be in Africa or Southeast Asia or South America, it doesn't matter. I tell them that they go and visit a travel doctor before they go overseas and they're advised they need immunisations. They head to the next door room where there's a professional nurse wearing a clean uniform in a clean room. I ask the patient now if the immunisation is something that they would normally be worried about. Most people who don't have needle phobia say, no, I'm not worried about the immunisations. So the nurse gets a small 25 gauge needle, cleans the skin and injects the immunisation. The needle passes through skin and subcutaneous tissue and into the deltoid muscle. I ask the patient whether they think that immunisation would have hurt, and most people say, no, it doesn't hurt, or it didn't hurt very much at all, or I didn't feel it. I explain then that the needle has stimulated nerve endings. It has damaged nerve fibres and caused a little bit of bleeding to the muscle. And those nerve endings have sent signals up to the brain. And then I explain that the pain we experience is actually our brain's interpretation of the nociception or the nerve signals, and that our interpretation can be altered or modulated by the way we're feeling. And at least part of the reason why we didn't experience much pain is because we weren't expecting it to hurt. I check at this stage that the patient understands this concept well. I then fast forward 2 weeks and they're on the plane overseas. Unfortunately, there's a delay at a couple of the airports along the way, and instead of arriving in the afternoon at 3 o'clock, they're delayed and arrive after 11 o'clock at night. And with the time through customs and getting their baggage, the line up in the cab queue, they don't get to their hotel till well after midnight. They go up to their room and it's hot and humid and sweaty and they're jet lagged, and they toss and turn for a few hours but can't get to sleep. So they wander downstairs, speak to the concierge and say, look, I'm just going to go for a walk to clear my head. Concierge says, sure, just make sure you turn left at each junction because then you'll get your way back to the hotel safely. So immediately they're in this new city they've never been to before. It's very exciting, there's lots of stimulus. And before they know it, they look around and they've realised they missed the first left turn and the street they've been on's been windy. They turn around 360 and they can't see the hotel. There's not very many street lights and the streets aren't named. But they figure, look, it'll be all right, I'll just keep walking, I'll take the next left, which they do. Before long, they've got themselves in a bit of a bind. They've reached the shantytown area of the city. It's very, very dark, very narrow streets. It's dusty and dirty, there's lots of smells. I ask the patient how they're feeling at this point. Most people say they're starting to feel worried or stressed, and I ask them how that manifests itself in them. Some people tell me that they feel their pulse racing or they feel sweaty or nauseous. I explain that this is the sympathetic nervous system doing its thing. I then say that you wander for a bit longer and now you're really lost and you're really starting to freak out. You're really worried and stressed. Your heightened sense of anxiety is driving everything. You're walking fast. Your hair's on end. And then suddenly out of the shadows, someone jumps out and puts a needle in your arm. They use exactly the same size needle as the nurse did. They insert it to the same depth with the same pressure. And I ask the patient how it feels. Most people tell me that it feels like they've been stabbed, and they tell me they'd probably scream, running away, holding their arm and asking for help. At this stage, I pause, I reflect, and I let that sink in. Then I ask the patient whether it's possible that for the last 6 or 12 months that they've been experiencing this terrible pain and the worry and the fear that it could be something serious, and they've been bounced around between doctors and tests. I ask them whether it feels a bit like they've been wandering around lost in an unfamiliar city at 2 a.m. I explain that when this fear response or anxiety or stress continues for a long time, these pathways that generate the pain response can be changed. The neurotransmitter densities can change, the nerve endings can change, and then it doesn't take much of a stimulus to elicit a pain response. In fact, it might even be that there's no significant medical pathology causing the underlying pain. I explain to people at this stage that it may be that it's possible to get some control back. You can learn techniques to help control your symptoms. I talk to them about breathing recognition and 4-4-2 breathing, where you breathe in for 4, out for 4, and have a pause for 2. I ask the patient to pause and reflect in 24 hours' time when they leave my emergency department. I explain I'm not going to cure them today. I just wanted to start a conversation. I want them to think about times in their life when their pain's worse, and ask them whether or not they have something stressful going on as well. And then I ask them to promise me that they'll go and see their GP in a week's time to have another discussion. Although you may feel that sometimes what you talk with patients about isn't sinking in, and sometimes that is the case, I'll just finish with an anecdote. A few years ago, I remember I'd spoken to a teenage girl and her mum who'd been experiencing chronic pain for 6 to 12 months and been through the ringer of investigations with nothing found. She'd missed 3 months of school in such an important time, year 11. I had the conversation about pain that I've just shared with you. 6 months later, I was doing my shopping and a teenage girl came up to me and she said, "You won't remember me," and I didn't. But she said, "You had a conversation with me about pain, and that conversation changed my life. I stopped going to the doctors and I didn't fill my pain relief scripts again. And I went back to school and I'm getting good marks. I'm going to be able to get into university." And although this isn't common, I think patients like this reinforce why it's so important to remember that at times our job as an emergency health practitioner is not to save lives or do something exciting, but it might be just to have a conversation to help a patient reframe their illness. I hope you enjoyed this talk, and as usual, any comments or questions, please put them below. I look forward to seeing you next time. Bye.